Hi and welcome. Today we're here with epilepsy experts, Dr. Thandar Aung and Dr. Jorge González-Martínez, both co-directors here of our epilepsy surgery program at the UPMC and the University of Pittsburgh. We're going to take a little bit of time and just talk about epilepsy treatment here today. So, Dr. Aung, let's start us off with what is epilepsy?
So people tendency to have a misunderstanding between the seizure and an epilepsy. Seizure is basically the symptoms of the epilepsy, and the epilepsy is a diagnosis. So sometimes we can diagnose with epilepsy if you have only one seizure, but the chance of having another seizure is high for cases with the abnormal brainwave study or the abnormal brain imaging. So then you can be diagnosed with epilepsy as well.
So how many people are affected with epilepsy and who can be affected?
So everybody can be affected with epilepsy, and then right now, according to the CDC, kind of like a data, is about 3.4 million people were affected, and then a majority of them is like adult, more than 18 years. So that is what is being affected. Yeah, and then epilepsy considered the fourth most common neurological disease.
Wow.
Mm-hmm.
So Justin, this is just complemented what Dr. Aung said. This is a very highly prevalent disease in our society that unfortunately affects patients with different ages and stages in their lives. It can affect infants, children, small children, teenagers, adults, and also senior citizens. So it's a very broad distributed. In our statistics, what we have in the U.S. is that approximately 3 million adult patients with epilepsy and around maybe 500,000 pediatric patients with epilepsy. But we do believe those numbers are very underrepresented. We probably have much larger number of patients with seizures. So it's a highly debilitating and highly prevalent disease in our society.
What are the different types of epilepsy?
So majority people for kind of to understand, there are two major types. One is what we call the focal epilepsy. One is what we call the generalized epilepsy. Focal epilepsy meaning that there's one part of the area in the brain which is responsible for the seizure onset, and then for the generalized is like a whole, like a more diffuse area of the brain involving both sides of the brain at the same time. So that is what we understanding as a layman term right now.
It's important to differentiate. A very common confusion is that there are, as Dr. Aung explained, focal epilepsy area, seizures caused by a very focal area in the brain, and generalized epilepsy, where the seizures are caused by a disturbance in the entire brain. But focal epilepsies, they can also have generalized seizures. And that's something that is a very common confusion. When we say focal and generalized epilepsy is where the seizures start. If they're starting from a small area in the brain, very focal area in the brain, we call focal. If they're starting from the entire brain, we call generalized. And the type of seizures they have, generalized seizures, generalized epilepsies can have focal seizures, and also focal epilepsies, they can have generalized seizures. So there is this very common confusion between what is seizures, generalized seizures, and what is generalized epilepsy.
That's correct.
Excellent. Thank you.
That's a good point.
So what is the treatment plan if the patient has failed anti-seizure medications?
So the first line, of course, like when we saw patients with epilepsy, the first main treatment is epilepsy medication. So that's the main goal. But if they fail, then it depends on how many type or how many drug that the patients fail. So if the patients already failed the seizure medication more than 2, that is appropriately chosen, and the patients really tolerate well, then the treatment is no longer the medications anymore. So in these particular cases, we are trying to see whether the patients can be a surgical candidate, where we can reset, or if the patients have the generalized epilepsy, which we just discussed. So in those cases, the neuromodulations or devices can able to help the patients.
Excellent.
Anything to add, Dr.
No, I think I agree. What is interesting is that the first line of treatment, as Dr. Wang is medication. Because we have very good response and, in fact, controls of seizures with one medication. So 50% of those patients will have their seizures controlled just with medication. If they fail this first line of medication, the next step is to give a second medication. And in this second medication, an additional 1/3 of those patients, they become seizure-free. But when you fail 2 medications, the chances for you to become seizure-free when we add a 3rd medication is extremely small. And then the risks of the seizures become higher than the risks of providing an additional medication. That is the point where surgery should be considered, because we know that the likelihood of those patients should become seizure-free with a 3rd, 4th, 5th medication are extremely small.
Yeah. So along those same lines, are there any circumstances where medicine is skipped over entirely and straight to surgery?
So yes, in particular, some cases that yes. So we know that if the patients have an abnormality in the brain, it's like, for example, related to tumor or some sort of like a lesion in the brain, we know that a medication is not going to help. In those cases, like facilitating or like expediting the epilepsy surgery is a better outcome than trying to control those patients with the medications. So in those particular cases, yes, we try to expedite it and then skip the trial of 2 medication.
Okay. Are there any tests needed before epilepsy surgery?
Yes, there are a lot of testing. It depends on patient to patients. So epilepsy surgery is a little bit different than other surgery, kind of like a brain surgery or tumor type of surgery. Is tailored to individual. So there's not 2 patients alike. So even though they have the same seizure type, so in those particular patients, depends on your brain MRI, depends on your seizure type, depends on how uncontrollable you are with the medications. There are other testing that we try to find, like non-invasive way by doing like a testing called a magnetoencephalogram, or like a brain metabolism by looking with a PET scan using the glucose parameter. Or there are other testing that we want to see where is your language and where is your motor region by doing the functional MRI. So there are a lot of testing go into that, because what we try to do with the epilepsy surgery is we try to localize the area which is responsible for the seizure foci. And at the same time, we don't want to give a deficit to the patient. So before we do anything, there's a lot of consideration going into it, and then there will be a lot of testing going into it. And then there will be some patients may need all the testing, but some patient doesn't need much. It's like just MRI and EEG, and then you can go for surgery. So it's variable. Do you agree?
I agree. Every patient will have a different type of workup. In general, what we see that all the patients will have what we call an epilepsy monitoring unit visit. As Dr. Wang mentioned, we need to see the type of seizures that the patients are having, not only the images, but what are the type of seizures, so we can understand what areas in the brain are responsible for that particular abnormality for the seizures. Some patients are very straightforward. Some patients are more difficult. The epilepsies are more difficult to understand. They will require additional testing. And then it comes what Dr. Aung mentioned about the PET scan, the MAG scan, the other components. But at minimum, an epilepsy monitoring unit evaluation, a video EEG evaluation is required in general for our patients, and of course the MRI, so we can really understand at a minimum where the seizures are coming from.
So if a patient is seeing a non-UPMC neurologist and is seeking surgical intervention, would they come directly to UPMC neurosurgery? Would they need to be evaluated by a UPMC neurologist?
So that is something that we are trying to do different here. So if you are seeing a non-UPMC neurologist and then they determine that you might be a candidate for the epilepsy surgery, then just contact us. We will review all the data. Main thing that we want to look at is the brain images and then also the video EEG. Then you will be scheduled at the UPMC Epilepsy Surgery Comprehensive Clinic, where you will be seen by both of us, the neurosurgery and neurology at the same time, and then the management and then a plan will be given on the same day. And then what we usually try to do is that we will coordinate with your non-UPMC neurologist so that he will be in the loop of this whole like a discussion, and then he will be along the line, and then he will be continue to be your primary neurologist. We just try to help out the way during the pre-operating periods and then the post-operating periods.
Excellent. Is there any data needed for a referral?
So mostly like Dr. González just mentioned, because we really want to see what is your seizure, and then because it's very individualized, the video EEG is going to be the mess, and then followed by the brain images. So those are the two data that we really needed to be reviewed before we see the patients at the epilepsy surgery clinic.
Apart from resection, are there any other surgeries that we do here at UPMC?
So resections, when we talk about epilepsy surgery, of course we are very focused on resections. That's what everybody has in mind. But in fact, epilepsy surgery it's much more vast and offers other types of surgical interventions. Resections can be very, very small and very localized. Unfortunately, for some patients, we will need to do larger resections, a little bit larger. But there are other types of treatments, for example, other modalities that we can be less invasive. For example, we can approach some of those patients with laser therapy instead of doing this with using a large craniotomy or an open procedure. We can insert a small catheter in the areas that we need to treat, and we can ablate those areas. We can disrupt the areas, and in that way we can treat that area. We like to reserve laser ablations or those procedures for patients that we specifically know from where the seizures are coming from. Most of those patients, they will go for an evaluation before the laser that we call stereotactic electroencephalography or SEG. This is a diagnostic procedure, epilepsy surgery, but for diagnosis reason, that we place electrodes inside the brain using small, little tiny electrodes that are placed percutaneously into the brain. So in that way, we can localize areas that we need to treat in a very precise way. And most of the time, what we believe is a large area that requires a large operation. When we do this method, we can understand that in fact the epileptogenic zone or the areas responsible for the seizures are very, very small. And those are the patients that are good candidates for other procedures, for example, the laser ablation. Other types of treatments is we talk about curative procedures, which is resections, laser ablations. But unfortunately, not all the patients are candidates for curative surgery for several reasons. Sometimes the areas responsible for the seizures are too large to be treated. Sometimes the areas responsible for the seizures are located on both sides of the brain. And we cannot treat both sides of the brain without consequences, serious consequences. So for those patients, we don't make the option of resection, but we do have the option of neuromodulation, where we put brain pacemakers that can target the areas on both hemispheres that cause the seizures, and in that way we can improve the seizure burden for those patients. It's very rare, unfortunately, that those patients will they completely stop in their seizures, but what we see is the improvement of the seizure burden, a decrease in the severity and frequency of seizures. So in resume, we have three types of different operations related to epilepsy. The type 1, which is the diagnostic surgeries, which is the SEG, which is the implantation of the electrodes in the brain so we can localize the seizures. The type 2 are the resections, the open resections, and the laser ablations, where it's designed for patients that will localize the seizures. They're coming from areas that we can treat, we can remove from the brain or treat without causing any deficits. And the third group of operations are the neuromodulation, the patients that, the seizures that we cannot treat because they are too widespread or because they are on both sides of the brain. And for those patients, the brain pacemakers or the neuromodulations are good options. So those are, in resume, those are the three types of operations that we have.
What does success look like on medication? Is that seizure-free? Is that manageable?
So that is a really interesting question. So it individualized. So for as a physicians, the main thing is that we want to control the seizure burden. As you know, that after you have a seizure in the state of Pennsylvania, you are not allowed to drive for 6 months. And then every time you have a seizure, you have to reset. So there's a lot of social economics, like a hit behind it. So for me, it's like, from my standpoint, the success for the epilepsy, like how to control is like by decreasing the seizure frequency or stop it. So what we are mainly to target by the epilepsy medication is that at least 1 year control with the medication, that is a success for me. But in terms of the patient, it will be different. So they want the like independence, and then they want to be like getting back the driver license and things like that. And then after you fail 2 or 3 seizure medication, and you know that you are not going to be seizure free for at least 1 year, is very slim. In those patients, that epilepsy surgery is going to be your goal. So success is based upon what the patients and their individualized. Do you agree?
I agree.
Yeah.
Yeah. It all depends about the patients, their expectations, how seizures are affecting their quality of life. And we all understand, as many times as epilepsy surgery has to go to treat the seizures. But we need to remind ourselves we're treating patients, and what is important for the patients sometimes are not necessarily the seizures. Yes, very important, but it's mainly the quality of life. So epilepsy surgery is designed to improve the quality of life of seizures of patients, not necessarily completely arrest of the seizure activity. Unfortunately, for some patients, we cannot afford. We will attempt to. That's the final goal. But the main aspect here is to improve the quality of life of those patients. I think this is very, very clear for us.
Yeah. So what does recovery look like after a surgical intervention?
Again, Justin, it depends on what type of surgery we are providing. So when we are talking about open resective surgery, in general, the recovery, it takes approximately 4 weeks. They stay in the hospital for 2 or 3 days. They go home. In general, the stitches are removed after 10 days. And for full recovery, we're talking about 4 weeks or so. For procedures like laser ablation, the recovery is much faster because we don't have big incisions or big openings. In general, those patients, they recover after 1 week. For procedures like SEG or even the neuromodulation procedures, which are percutaneous procedures, the recovery is also fast, approximately 1 week. The stitches, in general, for SEG, we don't even put stitches. They go home after we remove the electrodes, and they can go back to their normal life activities after 1 week as the neuromodulation. So, in resume, the recovery can go all the way from 4 weeks when we're talking about open procedures to 1 week when we're talking about the diagnostics and the neuromodulatory procedures.
So if a patient were to have any hesitancies about having a surgical procedure for their epilepsy, any misconceptions that you can sort of clear up for patients?
Absolutely. I think traditionally epilepsy surgery has been perceived as too invasive, surgical procedure that will not provide adequate results and will provide higher risks. And this was perhaps true in the past, but the surgery, the techniques, and the understanding of seizures changed drastically in the last 20 years. We have much more better understanding of how the seizures are organized. So we can localize the seizures in small areas in the brain, and we can perform small, many times not even open surgery in order to treat those patients. So that is a very common misconception, that epilepsy surgery is too aggressive. And then this causes the patients to avoid the treatment. This causes the patients to have years of seizures. And this is very detrimental for their lives, for their family lives, for their quality of life. There are years that are not lived well because of the seizures. So if you have seizures, if they are not treated with medication, we cannot control them, I strongly recommend patients to seek for treatment, for surgical treatment if they consider to be surgical candidates, because that will change their lives, their quality of life, their seizures, they will have a better life. And I think this needs to be done not later, but sooner. The sooner we treat the seizures, the less consequences from a socio-economic aspect, from an educational aspect, from a cognition aspect, the patients will have. So sooner is better than later. There are other misconceptions as well about epilepsy surgery. Epilepsy surgery perhaps is one small step in the treatment of patients that are candidates for surgery. What I'm trying to say is that this is perhaps the first step or the most drastic step, but those patients, they need follow-up after, before and after. We will not stop the medication soon after surgery. They need to be followed with our pathologist, with Dr. Aung. So slowly we will see what are the consequences of surgery in the seizures, and then Dr. Aung very cautiously will start decreasing the medication over a period that goes from 6 to 1 year to 2 years. Not all the patients will have the seizures completely withdraw. Of course, we'd like those patients to be completely seizure-free without medications, but some patients will require to stay with a maintenance dose of antiepileptics. But this is a process, as I understand. So that now means that they come here to do epilepsy surgery and they don't need any additional treatment. They will need after surgery treatment as well. So this is what completes the treatment, is the entire evaluation after as well.
Yep.
So how does the process go here at UPMC if a patient is interested in epilepsy surgery?
So it will be dependent upon what I would suggest is work with your primary care doctor or the neurologist, and then provide us with the data. Mainly is what type of epilepsy you have, and then what type of brain imaging that you have. Then we will review the data and we will get back to you. And then during the visit, you will be seen by both of us, both neurosurgeon and then also neurologist. And then we will work with you and then try to come up with a plan.
Justin, it's very important for patients to understand is when they come to see us. First, they will not come to see a surgeon or an epileptologist. They're coming to see our epilepsy surgery team. And this is something that makes a difference how we treat patients here in our hospital. Also, it's very important to have the message, or the idea is that when you come to see us, not necessarily you will have surgery. A lot of patients, they are concerned, oh, I'm going to see the surgeon and I don't want to have surgery, so I don't want to see anybody. So this is a misconception. So not all the patients that will be seen by us, we will offer surgery. Not all the patients we will discuss surgery. Many of our patients, they come and we can give better recommendations in how to treat seizures. And in fact, we prefer not to do surgery in our physicians. In fact, as we mentioned before, the first line of treatment is medication, but a medication that is well indicated and well provided to the patients. So our first attempt here is to treat those patients with non-surgical intervention. And then for some patients, depending on the type of seizures and things that we discussed before, yes, those patients will be offered surgery, but it's not necessarily certainly that they will come to see us. That means that we are offering surgery. This is a very common misconception that we have patients coming to epilepsy surgery services.
What makes University of Pittsburgh and UPMC a special place to come for epilepsy surgery?
Epilepsy is a complex pathology entity, and it needs to be treated by a multidisciplinary team. And when we say multidisciplinary team, is that not that patients will see different type of doctors. They are separated and they have different opinions. And in the end, the surgeons or certain epileptologists will make a decision. This decision is should be combined, and it should be centered at the patient's seizures, centered at the patient that we're seeing together. And this is what perhaps differentiates us from others, is that we do things in a very combined way. This is truly a multidisciplinary approach. And it's so multidisciplinary that we see patients together at the same time. So you come to see us, and you're not going to see the Dr. Aung, or you're not going to see Dr. González, but you will see both of us together, and we will discuss together, we will review the data together, and we'll make determinations together, whatever is the best for that particular individual. So I think this is perhaps one of the most important aspects that differentiate us from others, is the way we approach the patient. It's a patient-centered approach. Other things that in my concept are less important, but also that we do have all the types of different technologies available for our patients, at least from a surgical aspect and from the diagnostic aspect. We have MAG scans, very sophisticated MRIs, fMRIs, SEG, robotic surgery, laser ablations, neuromodulations, all different types of technologies with a very, very high expertise. So our group was one of the first to introduce SEG in the United States. We have an extensive experience with this method, with the techniques, with the surgical procedure. But quite frankly, Justin, this is perhaps not the most important aspect. What is the most important aspect is what I said first, is the evaluation of the patients, to see the patient together and make a decision. This patient needs this approach. This other patient will need this other approach. And this is very individual.
Thank you both for being here today with me and discussing epilepsy here at UPMC. And if you or you know somebody who's in need of epilepsy treatments, please contact us at the number on your screen. Thank you.
Thank you.